All right. I know we had a short break between the last session and this session. A few folks are still signing in, so I'll give my quick review of announcements before we get into our toxicology case reviews. So again, make sure if you haven't already, you want to attend each session, you've registered for each session. You should have a link for each session. If that's missing, let us know. Certificates of attendance will come out in about an hour after the end. I think most of you heard these, just gonna hit the highlights here. Again, if you have any questions, put those in the chat. You can, there's a questions area and a chat area. You can put them just in the chat, that way we just monitor just one. All right, so we'll look at that, make sure there's nothing there. And then I know this was a common question after the last one. Even though the next session changed topics, the link will still be the same. All I did was just change the title. So that shouldn't affect the links at all. So the link that you had before should still work for the next session. So that being said, I'm going to turn it over to Dr. Gadbois. She's going to enlighten us on toxicology for the next hour.
Thank you, Sean. Can you hear me okay?
Yes. Yep. Very good.
All right, thank you guys for your time and your attention this afternoon. And thanks Sean and his colleagues for putting on this conference and inviting me to be a presenter. I'm going to talk a little bit about toxicology regarding some cases that I came across. Some of them have been my own, some of them have been just interesting cases that I've read other people's case reports, but we'll start off with some Oregon stats if my stuff goes correctly. So I looked at Oregon Poison Control's website basically and looked at what stats they had. The most recent stats that they were able to produce were for the 2020 year. In 2020, they had a little over 52,000 cases. They reported about 45,000 of them were people calling because they had been exposed to something that they thought might be potentially dangerous. And then Oregon Poison Control doesn't just take phone calls from Oregon, but they also take calls from Alaska, Guam, and surrounding islands, and until recently, even Vancouver, Washington, but we've been told to call Washington. So in exposures of 2020, they separated out by reason why the phone call was initiated and age. So the vast majority of the phone calls were unintentional exposures, and then further broken down to intentional 21%, and then our next ones being adverse reactions at 3% and unknown or other for the representative 2% after that. As for age, the majority of the calls are going to be for people over the age of 19, 44%. The second largest group would be pediatrics under the age of 6, making up 42%. And they also put out a chart about what the top exposures were. And initially my plan was to cover potentially top exposures, maybe things that are a little bit nuanced, but I ended up not. So overall, the most likely cause for call to poison control is regarding analgesics. But when we look at children under the age of 5, it was more related to cosmetic, personal care products, and cleaning substances, then followed by analgesic. But the other age groups, the #1 reason would be for analgesics. All right, so we'll move on to the first case. The first case involved a 35-year-old. He was brought in for altered mental status, and the medications that he had prescribed or that EMS was able to get a hold of would included haloperidol, risperidone, and lorazepam. His past medical history provided by bystanders was bipolar disorder, depression, and post-traumatic stress disorder. His history was that he recently was prescribed procyclidine to manage his extrapyramidal symptoms, but likely related to his Haldol or his risperidone. He intentionally took his procyclidine. He took approximately 300 5 milligram tablets approximately 30 minutes prior to EMS arrival. Initial vital signs were notable for a fever at 38.2, heart rate of 130, hypertension at 190/110, a respiratory rate of 10, and a GCS of 8. His physical exam was most notable for that he was flushed in appearance and that his pupils were dilated. They got a 12 lead, which showed sinus tachycardia and evidence of a right bundle branch block. And in the emergency room, due to his inability to protect his airway, he was rapidly intubated, rapid sequence intubation. He received activated charcoal and was admitted to the ICU. So this is a case with anticholinergic toxicity. It's a common reason for why we come in contact with these patients both in the pre-hospital and the hospital setting, but it's rarely fatal. It's the 6th most frequent substance exposure that humans come in contact with. In that toxicity usually occurs secondary to the overdose with the anticholinergic properties. There are a lot of drugs that fall under the anticholinergic classification, and that includes atropine, icosapine, and hyoscine, as well as meds that have anticholinergic properties that are not strictly presented as anticholinergic, which include antidepressants, antihistamines, anti-Parkinson drugs, antipsychotics, antispasmodics, mydriatics, as well as Atrovent in your Duoneb. And then there are many, many plants that can also have anticholinergic properties. One example is Jimson weed, which is in this picture, E as in Edward, but all of these other common plants that have anticholinergic properties could be belladonna, Cestrum nocturnum, Cestrum diurnum, datura, lots of potential options that a patient could come in contact with. And that ingestion of multiple meds with anticholinergic properties have a synergistic effect. So that's something to take into consideration with patients that have polypharmacy or have multiple medications that other providers are not aware of that are contributing to their presentation. So anticholinergics mechanism of action, they block the binding of acetylcholine at the muscarinic receptor, and acetylcholine is a neurotransmitter. You can find the muscarinic receptors anywhere in the smooth muscles, ciliary body of the eyes, salivary glands, sweat glands, in the central nervous system. And it's important to kind of remember where the muscarinic receptors are because they also play into how these patients present when they're in toxicity. So with the ciliary body of the eye affects the pupil size, salivary glands, as we'll go into future slides, will affect secretions, and as well as the smooth muscle, which also plays a component to when there's toxicity. There is some blockage at the nicotinic receptors, but it's not significant. And when the anticholinergic properties are effective, it prevents cholinergic neurotransmission. That's mostly in regards to the parasympathetic nervous system, but to a small scale regarding the sympathetic nervous system. These patients will present with, actually the picture on the left shows a familiar toxidrome presentation that we maybe use to help us remember the signs and symptoms of these patients. But in general, they will be hyperthermic. So they also will lack sweating. They can be tachycardic. They can lead to arrhythmias like a wide complex tachycardia, QTC prolongation, specifically related to Benadryl overdose. There can also be decreased saliva, decreased tear formation, constipation, vomiting, reduced gut motility. They can also have urinary retention, dilated pupils. They can complain of blurred vision or loss of vision, and there may be jerking movements or seizure-like activity. So you may have heard it as hot as or mad as a hatter, blind as a bat, dry as a bone, hot as a desert, red as a beet, as some of the terms used to remind us about the signs and symptoms of this toxicity. Pre-hospital management, and I kind of break it down with pre-hospital management as well as hospital management, but a lot of it kind of overlaps, especially if you have ALS providers in your system. So there's certain things that we may not have in our protocols pre-hospitally, so that'll be referenced in the hospital slide portion of these cases. So As always, ABCs, IV is recommended. They may need IV fluids if they're hypotensive or dehydrated. Absolutely place them on at least a 4 lead, but I would stress and urge that you place them on a 12 lead because of the fact that they have a higher propensity to develop tachycardia and potentially wide complex arrhythmias. Poison control should be part of your pre-hospital treatment plan as well as our hospital treatment plan. And most of the management for anticholinergics is going to be supportive unless they start having seizures, which would be benzos, such as Versed. In the hospital, it's going to be similar where we're going to be repeating the ABCs, making sure that there has been no change that would need us to intervene. We'll be getting a complete set of vital signs. Usually that would be an addition of a temperature, although some agencies are able to get a pre-hospital temperature reading. We'll be continuing them on cardiac monitoring, repeating a 12 lead, and also making sure that if an IV hasn't been previously established, that we'll be establishing it and treating any hypotension. Now, you may say, well, these all sound like symptoms that could be related to a stimulant, such as cocaine or meth or something along those lines. And the differentiation between these two would be the clincher kind of, besides having the history that they ingested this certain item, would be that they're not sweaty. Anticholinergics are going to make you dry, where the other stimulants will make you likely sweaty or diaphoretic. We'll be continuing the supportive care in the hospital setting. We'll be treating agitation / seizure activity with benzos. And that's kind of a point that I wanted to bring up here, is that oftentimes these patients are altered. We know that there's a term to describe their symptoms as mad as a hatter. So they may be agitated, preventing care, or agitated, or potentially harmful to themselves or others. And you absolutely do not want to give them anything that's going to make their symptoms worse as another anticholinergic property. So that if your agency has the ability to give Haldol or Zyprexa, you would not be giving that to this patient because you would be potentiating their overdose on anticholinergics. So this is strictly benzo treatment. If the ingestion occurred less than an hour, activated charcoal may be an option. If they're hyperthermic, trying to make sure that they're not getting profoundly hyperthermic by taking off additional clothing, or maybe putting cool or wet sheet on them. And if they do develop a wide complex dysrhythmia that needs to be intervened on, the management of choice would be starting them on a bicarb drip as opposed to amiodarone or anything along those lines, medically managed, unless they are, of course, unstable, and then we would be synchronizing cardioverting them. Severe cases, patients that have both peripheral and central nervous systems presentation, would potentially get physostigmine. And if they are a Benadryl overdose that we cannot resuscitate, we have the option to start them on a fat emulsion. This particular patient was extubated and discharged home without any long-term effects. The second case is of a 60s female. The call to EMS was for altered mental status. Her past medical, well, I'll say the meds that they knew for sure that she was prescribed was clonazepam and Fiorinol, which would be a benzo and a migraine combination medication, but they didn't know her past medical history in its full details, or if she had any other medications. She apparently contacted her friends regarding her thoughts and intent to end her life. They contacted 911. When EMS got on scene, they were unable to get her to open the door, so they had to take additional time to break down the door. And they found her laying on the couch with empty pill bottles surrounding her. They don't know when she had ingested the med or how much of it she had ingested. And they noted that when they knocked down the door, she woke up and stirred a little bit looking at them, but wasn't able to provide any history or converse with them. They noted that she had some emesis on her face and her chest, but they noted that the emesis had no pill fragments. And the vital signs that they obtained showed a average weight individual with a normal temperature, a heart rate of 98, a normal blood pressure, a respiratory rate of 20, and a GCS of 8, end-tidal CO2 of 35, and a blood glucose of 120. Her GCS kind of waxed and waned, but actually never dropped below 9 after their initial assessment. They noted that her physical exam was significant, that she withdrew from pain and her pupils were 2 millimeters and reactive. Her 12 lead showed sinus rhythm, her QRS is 0.08, and her QTC was 422. Those are all within normal limits. And in the emergency room, when she arrived, she had a GCS more of like 7. So she ended up getting intubated. She received activated charcoal at the discretion of poison control because of her airway being managed, even though we didn't know when her ingestion was. And she had some bouts of hypotension following her RSI, which could be related to her overdose or potentially the meds that she received, but they responded to IV fluids. And her initial salicylate level, since we didn't know when she ingested, was 35, which was the cutoff that poison control was directing her bicarb drip to start at. All right, so aspirin mechanism of action. Aspirin, we typically think of it as our agent of choice for all of our cardiac patients, 81 milligram aspirin a day or 324 for chest pain, but it actually has other components that some people may not be aware of. So there's an analgesic property, antipyretic property, as well as anti-inflammatory properties. Most often it falls into the NSAID category because it inhibits cyclooxygenase or COX inhibitor, which relates to decreasing inflammation. When aspirin binds, it binds to the active site off of the cyclooxygenase, and it allows a serine residue, acetylates a serine residue. When it binds, it irreversibly binds, which is different from our typical NSAIDs because those are reversible and transient, and that is one of the reasons why when a patient comes in with potentially like a surgical need or a bleeding disorder and they're on aspirin, it's more of a deal because of the fact that it irreversibly binds to the COX receptor, leading for platelet dysfunction for the duration of that platelet's life. Aspirin comes in PO, rectal, liquid, and topical formulations. So that's something to be aware of. It's not just aspirin that we take orally. It could be Bengay, Pepto-Bismol, other types of routes that aspirin can come in. And it's frequently compounded with different active ingredients working to be kind of a one pill for all conditions, like in this case where this patient's Fiorinol had aspirin in it as well as caffeine and another agent to treat her migraines. So aspirin dosing, it's obviously weight-based or change for adults and children, as most medications are. Pediatrics, I have an asterisk here because really the recommendations are not there's no safety guidelines for under the age of 12, so they usually recommend not giving aspirin to less than 12-year-olds because of the possibility of Reye syndrome. Now the dosing is 10 to 20 milligrams per kilogram every 6 hours, up to 60 milligrams per kilogram per day. And from what I was reading, that's typically for patients that maybe are post chickenpox or varicella, although there are some conditions like Toxicology that would be giving aspirin. And depending on where you're looking at, the dosing might be a little bit different than what I'm presenting here. A lethal dose for any child under 10 kilograms, one-time dose would be a teaspoon of oil of wintergreen. As for adults, the recommendation is to start at 1,000 milligrams, followed by 650 milligrams every 4 hours to treat inflammation. And the lethal single dose for an adult would be 300 milligrams per kilogram. The toxicity range that we look for is doses greater than 150 milligrams per kilogram, or a salicylic acid level greater than 40 milligrams per deciliter. So I'm going to talk a little bit about the pharmacokinetics because I think it'll help you guys remember why we do what we do to treat these overdoses, both in the pre-hospital consideration, but also in the hospital management. So aspirin, its effects are usually within 30 minutes. It peaks at 1 to 2 hours, and its half-life is anywhere from 2 to 3 hours. And when an overdose exists, it's extended to 20 to 40 hours, so substantially increased when it's in when the concentration is high in the patient's body. And remember, it takes 4 half-lives approximately to clear a drug from your system. So although the half-life is 2 to 3 hours, you would be looking at 8 to 12 hours to clear that drug fully out of your body. And that's a little thing to consider, as well as that this gets a lot more difficult, or it's not straightforward with long-term ingestion of aspirin and chronic overdoses. So we're going to talk mostly about the acute management of an acute overdose. So when aspirin is metabolized, it's rapidly hydrolyzed to salicylic acid. And then it goes to the liver to be further broken down into salicylic acid, salicylic flucuronide, and salicylglucuronide, which is 90% of the breakdown product of aspirin, and the other 10% is going to be excreted unchanged into the renal system or in the urine. So what we recommend is that when you have a patient that you suspect that they've overdosed on aspirin, or that you believe it's a very high probability, but you don't have all of the information that clinches it, you want to ask when this was ingested, how much was ingested, what was the formulary, what was it mixed with, what was the component or the quantity of the drug in that pill. Were there any other ingestions that were also taken at the same time or near the same time, and was this intentional or accidental? Kind of speaks towards most overdoses. So aspirin overdoses can be broken down into 3 severities: mild, moderate, and severe. So in mild presentations, the aspirin stimulates the respiratory centers in the medulla, leading to respiratory alkalosis. If they have taken a CNS depressant or alcohol, they may not be hyperventilating initially. They may also be, the aspirin may stimulate their medullary chemoreceptors and lead to nausea and vomiting. Exaggerated antipyretic effects involving the hypothalamus can lead to vasodilation and sweating. There can be higher propensity for dehydration, and there can be electrolyte derangements involving sodium, potassium, bicarb, and calcium, which can further lead to arrhythmias, seizures, or tonic activity of their muscles. In moderate presentations of these types of overdoses, the increased salicylate in the body, in the serum, can lead to impaired cellular metabolism, affecting mitochondrial oxidative phosphorylation, leading to uncoupling, as well as inhibiting the Krebs cycle and affecting amino acid metabolism. All of this basically increases the lactate, and then it also increases the amount of fatty acids that are metabolized, as well as breakdown of glycogen and formation of glucose, all kind of leading to higher byproducts, leading to higher anion gap acidosis. The patient may or may not complain of ringing of their ears or ringing in their ears, and they can have neurological symptoms such as altered mental status, confusion, unresponsiveness. In severe forms, the patient can be pretty profoundly dehydrated, and coupled with the poor metabolic function, they can go into multi-system organ failure. And the increased acid leads to increased non-ionized salicylate in the serum, which leads to higher capillary permeability and higher levels of this toxin in the body, so that they absorb more and don't waste or eliminate more. And then you can also develop seizures.
Hey, Jackie, there was a question before you go slide on the pediatric toxic dose. I think you relayed the units in oil of wintergreen. Can you explain that?
Yeah, so that's more of like, so oil of wintergreen, I personally have never used, but I believe that that can be like a homeopathic or an herbal formulation for those that this is not, I'll double check here, but this is not something that you would get a prescription for. This would be some over-the-counter homeopathic remedy.
So the oil of wintergreen has salicylates in as well. If that's what you're saying?
Yes.
Okay, thank you. I think that was the question, but we'll verify.
Yeah, and you know, when I took my organic chemistry course, we created essentially oil of wintergreen, which is a component of altoids. So essentially, if you ate a lot of altoids, you could also, but I think we calculated you had to eat like 10,000 of them. So I don't think anyone's at real risk of overdosing on altoids. All right, so when there's a toxicity due to aspirin, elimination of this substance is inhibited. So like I mentioned earlier, the half-life extends now to 20 to 40 hours when it was previously 2 to 3 hours. It's really important for the renal excretion, and that renal excretion is affected by the glomerular filtration rate, as well as the ability for the proximal tubules to secrete salicylate, and for the distal tubules to reabsorb the salicylic acid. So that's why management would be to increase the amount of urine produced per hour and to alkalinize the urine. So alkalinization of the urine decreases the amount of reabsorption, and increasing the IV fluid so that you're hitting a urine output goal increases the drug clearance by effectively making more urine to excrete it and then not giving it a chance to be reabsorbed. These two processes, the alkalinization and to have a goal urine output, could help in eliminating salicylates by 20-fold or even higher. So pre-hospital management is going to include managing the ABCs, getting IV access, placing them on the monitor, and getting a 12 lead on them, and then poison control. I have poison control at the end because oftentimes, as you guys are probably familiar, they want a set of vital signs, what the intervals are on the 12 lead EKG. So I think that as long as you are doing this all pretty quickly, that it'd be helpful to have all that together for them when you talk to them. So hospital management is going to be similar with a couple exceptions. IV fluids are going to be potentially pretty dehydrated, may need up to 3 liters to replete them. And then our urine output goals are going to be from 2 to 3 mLs, it's a type of per kilogram per hour. Airway management is going to be pretty key to follow because of the possibility of them breathing so quickly that they're fatiguing themselves out, or there could also be pulmonary edema. If we're dealing with acidosis, we really are working on ventilating them, but we can potentially start them on a bicarb drip, in that we're going to be affecting their absorption when possible by giving them activated charcoal, or doing a gastric lavage, and then we're helping with controlling excretion by alkalinizing their urine and giving them IV fluids to increase their urine output. Sometimes these patients, if they've had a high enough toxicity, they may need to be hemodialyzed, so urgent hemodialysis. And if they develop seizures, it would be to treat them with benzodiazepines. I put in here just some aspirin overdose differential diagnosis, and as it's always helpful to consider other possibilities and not tunneling in. So those could be caffeine toxicity, they have been consuming ethylene glycol, they might be just septic, they could be withdrawing, there could be underlying mental health problem, as well as iron toxicity. So the differential is kind of wide for aspirin. This particular patient was admitted to the ICU. According to the notes I read, she remained unresponsive despite holding sedation. They don't think that she was necessarily hypoxic, but they think that the clonazepam that she ingested was probably pretty high and that it was taking a long time for her to metabolize it. I hadn't been able to follow up on her overall last outcome. All right, here is a 33-year-old male who, if you can't see that image very well, it looks like a 3-pronged fork on grass. And I don't know if this is something that is prevalent here in the Pacific Northwest, but when I practiced in Kansas, it was. So this is a case of a bite to the foot. This patient had presented by private vehicle, called in, I think 2 o'clock in the morning, asking if we were open in our emergency room, and said that he was concerned that he may have been bitten by a snake, and he believes it was a rattlesnake. He said he wasn't taking any medications, he had no past medical history, and his tetanus was up to date. He had reported that him and his friends were gigging that evening, early into the early morning. There was some alcohol involved. They said that when they were getting to the shore, he was bit by a snake sitting on the shoreline, and that he was wearing sandals. That's obviously not his picture, as this gentleman is at least wearing sandals. I mean, at least wearing closed-toe shoes. Vital signs: he had a normal temperature, heart rate of 110, a blood pressure of 136 over 87, a respiratory rate of 18, and a normal SAT of 98%. And his physical exam showed that he had 2 puncture marks to the dorsum of his right foot. So this might not be news to some of our listeners, but initially I thought, as my experience with snakes is that they're not usually as active at night, and that they seem to be more related to the warming up part of the day. I would understand if maybe he was going into a cave and maybe like disturb them, but the report of this snake being on the shore in the middle of the morning or early morning, I felt that it was probably not a rattlesnake. But the good news is that he said that he had the snake to show us. He told us that I asked him, well, is the snake dead? And he goes, yeah, the snake's dead. And with that news, I said, well, go ahead and have one of your friends bring in the snake. This is the picture of the snake. It was not dead, and we quickly removed it from the emergency room. But as you can see the end of the snake's tail, clearly a rattlesnake, and you can see its head here. The prongs had just kind of pierced through halfway through its body, but it was not dead. It was still flickering its tongue when they brought it within feet of my face. So we irrigated his wound, we placed an IV, we got some labs looking for the telltale signs of envenomation, and then we measured his foot, as we'll talk about in future slides, and then we contacted poison control. So snake bites, we're going to talk about our poisonous snakes, and those are going to be, at least in the United States or Northwestern America, is going to be our pit vipers or our Crotalinae. I don't know if I'm saying that right. And our coral snakes are Lapidae. Pit vipers, their venom is coagulopathic, and our coral snakes are neurotoxic. There's approximately 10,000 visits per year reported for snake bites, and a third of those snake bites are going to be venomous. This picture over here on this table, let's see here. So approximately, in a 9-year period, 2006 to 2015, there was 63,695 reports of these snake bites, these venomous snake bites. Approximately 35,000 of them are going to be our pit vipers, and copperheads being the most prevalent source for snake bites, and our rattlesnakes are coming in second at 11,500 approximately. These occur more frequently in male individuals between the ages of 18 and 49. Usually occurring in the warmer months. The particular case that I talked to you guys about happened in June, and that it peaks around July, and that if the snake bite is provoked, it's usually involving the upper extremity, their finger, their hand, their forearm, and if it's unprovoked, it's usually involving the lower extremity. Where I come from, Colorado, that it's a major problem with mountain biking that you could potentially get bit by a rattlesnake just riding along, as well as potentially if you leave your bike outside, that they crawl underneath the bike saddle to try to get some radiant heat off of the seat. So something you have to be cognizant about. Even if you don't leave it out overnight, you just leave it out unsupervised while you're taking a break or a lunch. So some snake bite factors. The amount injected, there's a possibility for a dry bite. Usually that's related to snakes that are not biting because they think that they're hitting prey. Usually this is like kind of potentially as a reflex bite. And then the other thing is that they say, and I didn't necessarily find it confirmed on the research I did for this lecture, but they say that smaller snakes are more likely to have, like baby snakes, are more likely to have envenomation, and they have a more difficulty in controlling the amount of envenomation that they produce, so that you're better off to be bit by a bigger snake. And then venom composition, if this a coagulopathic or a neurotoxic envenomation. And then the human factors would be clothing. Obviously, the jeans tend to be a little thicker, so there's some protection against the bite to your body, especially if you're wearing, as like I was mentioning earlier with mountain biking, if you're wearing any kind of shin guards, that could potentially help you. Body size, if you're a smaller individual, you're more susceptible to adverse reaction to the envenomation than if you're a larger individual, so kind of thing like pediatric or like a very skinny person. And then pre-existing conditions, if you have a propensity for asthma or allergic reaction, this could be pretty devastating. We had a case in Colorado where we had a young individual hiking and was bitten by a rattlesnake, and unfortunately had developed an anaphylactic reaction leading to cardiac arrest, and there was difficulty in getting to him in a expedited manner, in that ultimately he was unable to be resuscitated. And then the circumstances of the bite, as mentioned earlier, is this a prey bite or is this a reflex bite because you came into their territory? And then any medical care received. Now, the human factors on medical care, it could, you would say maybe any care is good, but you probably are familiar with the fact that there's been so many different recommendations throughout my medical career about how to manage snake bites, including sucking the wound, suctioning the wound. Those are not recommended. So those could be actually disadvantageous for the patient if we provide the wrong care for them. So snake bites, pit vipers, they have the components that are listed in the second column here. So low molecular weight polypeptides that lead to capillary leak. If the leak is significant and over a large area, it could lead to shock. The metalloproteinases lead to hemorrhage. Fibrinolysins lead to coagulopathy. Digestive enzymes cause tissue damage, and the myotoxins cause muscle damage. And then as for the coral snakes, the Lapidae, they their venom contains alpha neurotoxins that can affect their neurological system, as well as phospholipase A2, leading to soft tissue injuries, and they also contain myotoxins that lead to muscle necrosis. There's something else. Both of these envenomations can lead to some tachycardia and tachypnea, especially if there's an anxiety component to it. And I will say that the literature that I found said that you're more likely to have a bad or adverse event to a rattlesnake as opposed to coral snakes, that there's only been one documented death from a coral snake. So going into identification of venomous versus non-venomous, specifically in regards to pit vipers. This image here on the left-hand side kind of helps break that up for you. So venomous are going to have a triangular head. They'll have a heat-sensing pit behind their nose. I'd probably say you're not really going to be looking too hard for that heat-sensing pit, but just be looking for this triangular head, or treat all snakes as avoiding them unless you're familiar with identifying them properly. Also, I probably wouldn't advocate for you to flip the snake over for the underside, but I would advocate to look at the tail, looking for rattles. There could be maybe only a few. You don't necessarily have to have 5 or 10 of them. Non-venomous snakes, so going back to venomous snakes or pit vipers, they're going to have permanent teeth, permanent hollow teeth, where our non-venomous snakes are going to have no teeth. They'll have a round head, they have round eyes, round pupils, not like this elliptical size pupil that the pit vipers have, and they won't have a rattle. So this is a picture of a rattlesnake, and this is a picture of what we have in Oregon. Does anybody know, and I'll have to ask Sean to see if anyone answers, do we have coral snakes in Oregon?
I wouldn't think so. I think those are more of a tropical Florida area snake.
Yeah, absolutely.
Unless they had a pet.
What's that? Unless they're pets, exactly. So we have 15 indigenous snakes in Oregon, and only one of them is poisonous, and that's our rattlesnake. This is a picture, I believe it's a king snake. The milk snakes were white and black, but this is a king snake. And the other portion to know is that growing up for some period of time in Florida, that was part of our elementary school training, was how to identify a coral snake from a non-coral snake. So from a very young age, I have been taught to know that red on yellow, kill a fellow, red on black, venom black. So this is red on black. This is not a poisonous snake. So distribution of rattlesnakes is depicted on the left side. We are into that category of where rattlesnake territory exists. And then the picture here on the right side is the 3 different types of coral snakes, and none of them are, unless they're an exotic pet of somebody's, do not reside in Oregon or Washington. So treatment really should be to get that patient en route to the appropriate hospital, and not to spend too much time on scene, as if these patients are needing intervention, oftentimes it's going to be something that we don't have unless they're anaphylactic. So doing ABCs and identifying the snake. When I was putting this lecture together, I found this Snake Snap. It's a free app that allows you to take a picture of a snake, and it's supposed to identify what type of snake it is. Sure. Otherwise, just take a regular photo. And then you want to decrease cardiac output by keeping the patient calm, having them rest, keeping them warm. You want to remove anything that's constricting to the affected limb. So any rings, any tight clothing. And then you want to splint the affected limb to the level of the heart, or you can have them raise their hand above. In my experience with the patients I've taken care of with rattlesnakes is that we put them in the position of comfort, and they usually identify that pretty quickly. You want to keep the wound clean. You want, they say, to keep the affected joint in extension. to help make sure that there isn't any kind of reduced flow to that area, and that you want to add any pressure points to make sure that it doesn't lead to any necrosis. You want to monitor vital signs. You want to monitor for altered mental status, as this altered mental status could be the first signs that the patient is developing anaphylaxis. And you want to place an IV in the unaffected limb. And then you want to mark the leading edge every 15 minutes. So here's a picture of somebody who got bit on their finger, and marking the leading edge of either the ecchymosis, the erythema, or the complaint of pain every 15 minutes, because that is part of our management in the hospital setting. So in the emergency room, we'll be continuing on ABC assessments. We'll be marking the leading edge every 15 to 30 minutes and then putting the time. So that's what this image here on the upper right is showing you. We'll be contacting poison control as well for further guidance. And we'll be treating shock or anaphylaxis as appropriate, or as we would any other type of condition. The antivenom or the crofab does not reverse anaphylaxis. We'll be checking the patient for their neurovascular exam frequently, because there could be it could continue to have swelling to the point where they lead to compartment syndrome. We'll be checking labs. If the patient does complain, we'll get a 12 lead because the potential for neurotoxicity affecting the cardiac system, and potentially for pulmonary edema from this bite. So we'll get a chest x-ray, and we usually observe them from 6 to 12 hours at minimum if we think that there's a dry bite, or if there might be like a minimal envenomation. My experience personally or anecdotally is that if we think that this is anything but a dry bite, we usually admit for observation. If they do get antivenom or crofab, they get admitted, and that's usually for patients that are very symptomatic, or if they develop coagulopathy identified by laboratory testing. And then if compartment syndrome ensues, they may need like a fasciotomy, as this picture here on the right kind of shows. This particular patient was monitored in the emergency room for 12 hours, serial initial labs and coags, and 12-hour coags were obtained, which we've assumed that given he had no symptoms and no laboratory changes, that he likely just had a dry bite from that snake. All right, our last case is of a 3-year-old who got her hands on some Quicksilver tire cleaner. So the call was for an ingestion, no reported past medical history, no reported medications prescribed to her. And the mother of the child stated that she drank 1 ounce of Quicksilver wheel cleaner approximately an hour ago because she got into it unsupervised. And that mom contacted poison control, who recommended that she be transported and evaluated immediately. Vital signs that were obtained showed a heart rate of 80, blood pressure of 196/55, a respiratory rate of 24, and an SpO2 of 99% on room air. Now, looking at whatever device that you use to confirm vital signs, if that's hand heavy, or if that's the PD wheel or the Broslow, you verify that these are normal vital signs for a 3-year-old. The kid looked well, non-toxic. You didn't find anything abnormal, in that because of the complaint of ingestion, you did a very thorough oral pharynx evaluation as well as a pulmonary exam and found no abnormalities. Transported to the hospital, supportive, and at the hospital they got a 12 lead, and the 12 lead shows QTC prolongation, but nothing else on this EKG that sticks out. How I got this case was not my case, but it said that that poison control recommended management stabilization at the hospital, and that the the physician didn't feel that the kid looked too good to really do much resuscitation and was in the midst of transferring the child out, and that the child arrested on the helipad. So what's the issue with this ingestion? How could you potentially identify or be anticipating what happened in this situation? So wheel cleaners, as well as cleaners for brick and patios, has ammonium bifluoride. And ammonium bifluoride is represented on the left side of this chemical equation. And when it comes into contact with water, it turns into hydrofluoric acid and a fluoride ion. So this is your big issue. So hydrofluoric acid is highly corrosive. It's the most electronegative ion, and it is very likely to bind up all the calcium and magnesium that it can come into contact with, and that as little as 45 cc's of a 5% solution will bind all of a individual serum calcium. Massive doses of calcium may be needed. 1 gram of calcium chloride may be needed to bind 6 cc's of 5% hydrofluoric acid. And looking at that, it said that 45 cc's would bind all of the serum. So you're thinking you would potentially need 7 grams of calcium chloride potentially with this type of ingestion. Or potentially more, but just based off of that word problem. So survival has been reported, but it's usually associated with massive doses of either calcium in the form of gluconate or chloride. So pre-hospital management is going to be ABCs, IV, monitor, and contact poison control. If you're an ALS system, likely they're going to be telling you to monitor closely for the signs and symptoms of this ingestion, which would be the hypocalcemia, hypomagnesemia. They might lead to CNS depression and definitely potentially to an arrhythmia, non-perfusing arrhythmia. In the hospital, you're going to be continuing the ABCs. If we don't have IV access, we would at least get a peripheral line, if not consider a central line because of the toxicity of calcium chloride in a peripheral vein, in that we'll be giving calcium, maybe needing up to 5 doses just to start, and then we'll likely be repeating it as we monitor the individual's serum levels as well as their arrhythmia development, and then they would potentially also be started on a bicarb drip and amiodarone. One of the things that you should be thinking about if you're ever in this type of situation and this type of exposure is that, you know, you're gonna shock like VFib, because this particular individual went in the VFib, but the management is going to be calcium, calcium, calcium. So we're not really going to be spending as much effort into, you know, if you have this suspected condition, be working with epinephrine or amiodarone, or, you know, the patient could benefit from calcium and mag if their arrhythmia was related to this exposure. So they're unable to resuscitate this child, and she was pronounced dead. So points to remember of the 4 cases: that anticholinergic ingestions were going to be, or exposures, that there are many agents that have anticholinergic properties in them besides just Benadryl and atropine, and that you should be aware of knowing what to look for. Back to that, mad as a hatter, dry as a bone, red as a beet, I think something flushed. No, that was anyways, just make sure you remember all the components. If not, have a good place to reference it. And the management is largely supportive unless they're seizing. So you'd be giving them a benzo. If they're agitated, you're not going anywhere near your antipsychotics to try to manage their presentation, as that's just contributing to their anticholinergic ingestion. And that if they do develop a wide complex tachycardia, that they could likely benefit from sodium bicarb drip. Aspirin has many potential indications to be administered: antipyretic, pain, as well as anti-inflammatory or antiplatelet therapy, and that the mechanism action is that it really inhibits normal cellular metabolism, leading to lactate elevation, as well as trying to get the energy to continue normal metabolism, leading to breakdown of glycogen and gluconeogenesis and breakdown of fat. So similar kind of presentation in the metabolic acidosis component as your as your DKA, or so they're going to be very dehydrated. You're really working on hydrating them, but then how our management is going to be affected besides IV fluids in supportive is to also try to eliminate any further absorption with activated charcoal, and then working to give them enough fluids to maintain their urine output, and they may, depending on their ingestion, need to be on a bicarb drip. This individual, which was me, identified the snake appropriately as a bull snake, and although I identified it appropriately, but you should not make foolish decisions unless you are pretty sure what you're picking up. But in addition, that the only things that we need to worry about natively in Oregon would be our rattlesnakes, and trying to avoid exposure whenever possible, in that we're really being supportive, making them as comfortable as possible, getting to the appropriate hospital, and managing anaphylaxis appropriately while you're transporting, and also in the hospital setting, and then they may end up being treated with antivenom. Quicksilver or hydrofluoric acid exposures are really scary, and although I have never had one myself, it sounds like that they're okay until they're not. And that the one case study I was reading, there was 5 pediatrics that had ingested some of this cleaner. 2 of them leading to cardiac arrest. I believe that all of them survived that case study, but just being aware that this is not this is a major potential emergency for ingestion. And don't forget the importance of poison control. The nice thing is that this number is the same no matter where you're calling it in the United States. So if you can't remember what it was in Oregon, it'll be the same number wherever that you're at. So you can utilize that number, look it up. It's a great resource. And personally, coming from a training center that had a poison control based out of there, I call poison control even if I don't feel like there's a lot for me to gain from them, because they're federally funded, so they report their usage, and that if we make phone calls to them, they have more justification to continue being funded and being a resource for all of us. All right. Any questions?
All right, let's see if we got any questions in the chat or the question box here. We got a thank you.
Okay.
Great presentation.
Okay, yeah, I think that last one, Quicksilver, it's in the name, right?
Yeah.
All right, I don't see any questions. There was a question earlier, and I assume I answered it correctly, but Crofab is just the antivenom that's specific to the rattlesnake family. Is that correct?
Yes. Or not rattlesnake, the pit viper.
Pit vipers.
And I'm gonna look up real quick because there was a second one. Oh, Anavipe. Anavipe versus Crofab. So this came out, I want to say a few years ago, but Anavipe is dosed differently than Crofab. All snake bite envenomations should start with a call to poison control, and they'll help guide you on which one, because not everybody, from my understanding, not everybody has access to Crofab or Anavipe. And so a couple of things I would mention too is that that not so not everybody has access to it. And where I was working in Kansas, the surrounding hospitals or emergency rooms didn't have CroFab, so they actually had to transfer patients to our hospital for access to CroFab. Assuming like our Eastern Plain, Oregon hospitals have CroFab, that would be good to know. Likely, I imagine it's kind of rural, so you wouldn't necessarily be able to drive further away, but maybe you would be recommended to drive to the hospital that actually has CroFab so they don't have to transfer them. And I can tell you places that, like, for example, in Colorado, in Kansas, that you could purchase services where they would expose your dog to bites from rattlesnakes to make them immune. I never actually participated in that, but supposedly that's how they would operate to allow your dog to run freely while you're out hiking and not be exposed, not be negatively affected by a rattlesnake bite.
One of the questions was, what do you have to say about anything about, have you seen any cannabis toxicity, and possibly how would you treat that?
Yeah, so that's a good question. I would say that 2010, 2011, Colorado, I think, was the year when Colorado legalized marijuana. And at the time, we would see people just using it a lot. And I think that what we're more likely to see is cannabinoid hyperemesis from just smoking pot or consuming, I'd say smoking pot, and usually, and then patients that would come into Colorado and use edibles at such high doses, they would oftentimes just be so incapacitated that they couldn't make it to their flight or couldn't get back to wherever they were staying. So those would be the two. Now, dabs, the cannabinoid dabs, those we had a pre-hospital presentation where a 2-year-old got into their parents' dabs and was unresponsive, GCS of 3, which is a highly concentrated version of I have to look it up again, but basically of the active ingredient of marijuana, and that they were just like, the kid was super, super high for the amount that she ingested. So it was supportive. I don't think that I'd have to double check, but I'm pretty sure that we did not intubate her, but we transferred her to a children's hospital so that she could be monitored closely.
Yeah, I know we have a repeat frequent user hyperemesis patient that her issue is we can't get her to stop smoking the marijuana.
Yeah, I mean, so like a good question to ask, which they still don't put it 2 and 2 together, is do you feel better when you take a hot shower, or has hot showers been helpful? That's one of the positive treatments that they could do. And then what we tend to do with our cannabinoid hyperemesis is that capsaicin cream can be very effective applied to the area. And if we don't have capsaicin, like to their abdomen, and if we don't have capsaicin cream, I've seen some places, some physicians MacGyvering it by getting Tabasco and putting Tabasco from the cafeteria on their abdomen, and also working to the same kind of process as capsaicin cream.
All right, I think that was the last of the questions.
Awesome. Well, thank you guys for your time.
Thank you. Yeah, so thanks to you, everyone. The link is not different for the next session, just the name changed. So we'll see you all in about 10 minutes.